Hello everyone, my name is Luis Augusto Palma. I'm from University Hospital's Cleveland Medical Center, and on behalf of the other authors, I am pleased to present this case of OCT-guided left main treatment with hot ablator and Impella support, intravascular imaging guiding the decision-making process. I have no conflicts of interest with this presentation. So the history is a female patient, 85 years old, with previous history of hypertension, dyslipidemia, severe osteoarthritis, coronary artery disease, and previous PCI to the first obtuse marginal. The patient was admitted for fracture height radius, and her hospitalization was complicated by a non-STEMI. Her left ventricle ejection fraction was 50% and moderate aortic stenosis and moderate mitral regurgitation. The angiography showed multivessel disease, including a severe lesion of the proximal RCA and a severe heavily calcified lesion in the left main bifurcation, apparently involving both the ostium of the circ and of the LAD. Medina classification 111, syntax score 40. Surgical procedure was not recommended by the heart team due to frailty and anticipated difficulty of rehabilitation of the patient due to multiple falls and arthritis. So she was referred for PCI of the left main bifurcation with circulatory device support with Impella and staged treatment for the RCA disease. So our initial strategy was a two-stent bifurcation technique using a rotational atherectomy of the unprotected left main. So we decided to use an Impella to support hemodynamically the patient during the procedure and using an OCT to guide the procedure. So this is the RCA. So this is an image. You can see the RCA with a lesion in the proximal part. And then here you can see the left main with a bifurcation lesion, most probably involving both the LAD and the circ with a heavy calcification. So here the still image showing a severe disease, calcified disease in the left main, Medina 111, and we were proposing the treatment of this bifurcation with Impella support to avoid any complications in the procedure. Here another view of the left main showing the severe lesion with calcification. So we were proposing the utilization of hot ablator. And this is the left femoral access, a good access. So initially we performed, we were about to perform a two-stent bifurcation technique using hot ablator for the unprotected left main, and we decided to do the hot ablation in the circ. So this is the OCT imaging after the hot ablation of the left main to the circ, okay? And here, this is the still image showing that you have a severe lesion in the ostium of the circ even after the rotablation. But for our surprise, when we took a look at the ostium of LAD, we saw that the LAD was not compromised. So the OCT image that you can see in this figure is showing the catheter inside the circ with a severe lesion in the circ, but the ostium of the LAD, that's this big image below the catheter, showing like the LAD ostium with a great area, over 4 millimeters square. So we decided, based on that, not to use a two-stent technique and to keep on the one-stent technique, just provisional stent to the LAD. So the idea was to treat the left main to the circ and then only a provisional stent if necessary to the LAD. So this is another pullback from the LAD. So you can see the catheter inside the LAD with a big lumen area of 6.26 millimeters square. And so we decided not to treat this lesion of the LAD and just treat the lesion from the left main to the circ. So basically, after all these considerations, we decided to perform the treatment of the left main to the circ. So we pre-dilated with a non-compliant balloon 3.5 over 12 millimeters at 12 atmospheres. Then we stented with a DES 3.5 by 23 millimeters at 12 atmospheres. And then we performed the pulse dilation for the circ with a 3.5 balloon at 24 atmospheres, and for the left main with a 4.5 millimeters balloon, non-compliant balloon at 2480 atmospheres. This is the final result that you can see from the circ, with a great result, great expansion with a lumen area of over 14 millimeters square, and without compromising the ostium of the LAD, with a great result. So you can see here the final result from the great result from the left main, from the circ, and with a patent ostium of an LAD. So we turned it like a procedure that would be complicated with the use of two stents into a single stent procedure, and without any complications, with a great final result. So for the discussion, the Impella provided hemodynamic support during the high-risk PCI procedure, allowing time for adequate lesion preparation, intracoronary imaging, and stent optimization. By the end of the procedure, the Impella was weaned off successfully inside the cath lab, so the patient left the cath lab without the Impella and completely stable. The immediate outcome was good, and the patient was discharged home uneventfully the next day. And the decision-making defined by OCT changed from a two-stent bifurcation procedure into a simple single-stent procedure, successfully performed by our team. So the conclusion is that we highlight the importance of protected PCI in an unprotected left main using rotational atherectomy. And OCT is a game changer in the left main bifurcation scenario when appropriately interpreted and proper reaction applied. Thank you very much for your attention.